First, thanks to everybody who is here watching. We're really excited to be able to bring this conversation to you. We're really lucky to have this amazing panel of people who have varied experiences in the space of specialty medicine and how to use virtual care to solve some of the service delivery problems that each of us face. It is very telling by the number of people who are on this call how important this conversation is. And so I'm really excited as part of Collaborative Care Coalition to be partnering with the Veterinary Virtual Care Association to bring this to you tonight. So first, just a couple of things about Zoom. If you are not familiar with it, this is a Zoom webinar, which means that our panelists and Ali and I as moderators are all able to speak and on video, but all the rest of you as attendees, you do not have audio or video on this call. So what we will ask that you do, if you have any questions, is to type them in the Q&A section. If there are opportunities, and there will be as we move forward, for you to send chats as well, just make sure that if you send a chat that you're sending it to either all panelists, in which case only the people on the panel will see, or you can send it to all attendees as well. We are recording this and we will be making it available. So I think our plan is to put together some highlights from this conversation, and then we'll be sending out a follow-up to anyone who had registered for the event so that people can access it. So if you have colleagues who wanted to be here but couldn't be, don't worry, there will be more information coming. With that, we're going to try and turn it back over to you, Ali.
Great. I just changed to a different network. We'll see if that helps. Can you hear me okay?
Yes.
Great. Okay. So if you want to go to the next slide, I just wanted to give a few minutes of brief overview about what the VVCA is all about. I'm not going to read this slide to you, but the most important piece is that our mission at the VVCA is to elevate the standard of care in veterinary medicine through the use of virtual care tools, telemedicine, telehealth, everything, really. We believe truly that that the use of virtual care tools can elevate the standard of medicine. And that's really what our mission is to prove and to educate about. Next slide. I wanted to give a huge shout out to our charter sponsors. These were all 3 sponsors that came in last year, which was our founding year. Charter sponsorship is our highest level. And then if we go to the next page, you'll see our next level. And, you know, just thanks to the industry, thanks to the profession for believing in us and trusting that we were going to do good work and bring forward our mission. We've done a lot. We did a ton in 2020. And we're growing really fast. 2021 is going to be pretty exciting. If you go to the next page, I'll show you a little bit about why. So I think many of you probably have seen my announcements about our new community. We just launched this past weekend a membership, a formal membership to the VVCA that includes access to our VVCA community, which is built on a network platform called the Mighty Networks. It's a really unique platform that brings people together outside of social media, but it still feels a little bit like social media. It's really well organized and it's very collaborative. We're just getting started, so please take a look at our website. If you click on the community button in the upper right corner, that will take you directly to the page we're on right now. And there's also other ways throughout our website. There are other ways to find the registration pages. So lots of opportunities to find that on our website. And I just wanted to say thanks so much to Joanne for bringing me into this conversation and for planning this with me. And I'm looking forward to a good time tonight.
So then there's the Collaborative Care Coalition, and some of you may not have heard of our little organization. Our mission is very simple. We aim to achieve optimal health care for animals, advance the veterinary profession, and evolve the relationship between primary care veterinarians and specialists. We're formerly known as VetSoap. And we actually came together to do just these things. And so we've done some novel research that we are working on publishing now. And we are launching a educational program to help specialists better collaborate with primary care veterinarians, and to help primary care veterinarians to be more aware of how they can work best with the specialty world. So we were founded on this premise that working together for animals isn't just good medicine, it's also good for business. So our sponsors, we're so grateful for these organizations that have really been a super important part of helping us to move forward. And ACVS and Zoetis in particular have been platinum sponsors for us from the beginning and have been a huge part of helping to drive our mission forward. So what I was just mentioning is our collaborative care partnership program. And this is where specialty hospitals can become collaborative care partners. And as part of that program, you and your whole hospital team will learn some of the best practices for collaborative care that's based on our research and data. You're able to differentiate your own top referrers to pet owners. You're helping to fund future research, which we're actually we're working on a new survey of the pet cancer owner community funded by VCA. And we're really excited about that study that is getting started. And we'll be able to share all of those results with everyone. And you're also educating all the stakeholders on the benefits of collaboration, so we can actually help to educate the primary care veterinarians in your community. You also get access to this toolbox that includes a self-assessment, a survey of primary care veterinarians, strategic planning tools, and marketing tools, including a seal that shows that you're a collaborative care partner, and other marketing materials you can use on your website or brochure or whatever, as well as a best practices list that was developed by a team of veterinary consultants that we hold in very high regard, and have helped us to develop this list of what are the things that specialty hospitals can do to be the best collaborators with the primary care community. So if you are interested, you can email me, Joanne at collaborativecarecoalition.org, but we will also be sending follow-up information to all of you that will have links and all of that information that you can access for sure. We just wanted to start actually by doing a quick poll so that we can better understand who is in the audience. So hopefully you all have popped up on your screen some questions that you can answer. First, what is your role in the profession? And yes, this is the same question we asked when you registered, but we wanted to get a feel for who is actually here. And then, do you use video conferencing with clients? Do you use texting or a similar app? So whether that is something that's part of your practice management software or Slack or anything like that. And do you do that? Do you use texting or something similar in your communications with referral partners? So whether those are, if you're a primary care vet, that might be the specialist that you're communicating with. And if you're a specialist, it might be the primary care vets that you are working with. So we'll give everyone just a minute to answer these questions. We're at about 50%, so keep going. We'll give you another minute, and then I'll share the results with everyone so we all know kind of where everyone's starting. I know from talking with some of the people who have joined this call that it's the concept of virtual care is something they want to do and have considered. They just don't see how it can work. And that's the point of this conversation. So you can talk to people who use it in real world scenarios and are living it every day. Okay, it looks like it's slowing down. So I'm going to end and share the results.
Look at that.
So hopefully you all see. So we have a lot of people from industry today, but also a good number of primary care vets and specialist veterinarians, as well as people from across the veterinary team. Do you use video conferencing with clients? 44% all the time. And do you use texting? 35% all the time. And do you use it with other veterinarians? Much less, for sure. So that's an interesting part, because I know there's definitely people on our panel who use texting to facilitate communications between primary care and specialist veterinarians. So, okay, let's see if I can close that. So COVID-19 has really highlighted and exacerbated issues that many specialty hospitals have faced for years and years, but it has also shined a light on virtual solutions that may be of help. And that's why we at the Collaborative Care Coalition decided to partner with the VVCA to host this important conversation and bring together this diverse group to talk about how they're each approaching virtual care. So we want to start by just introducing everyone on our panel, and to have you tell us why this conversation is important right now in veterinary medicine. So Dr. Teller, we can start with you.
Hi, thank you. I'm Dr. Lori Teller. I am on faculty at Texas A&M, a clinical associate professor teaching in the primary care rotation, so I am a general practitioner. And I also am developing the telemedicine program at the university, the only university that has a full-time faculty member devoted to telehealth. So that's pretty exciting. Why this particular conversation is important to me is a couple of things. First, being involved in academia, I have a rotation that's dedicated to teaching general practitioner, but I'm surrounded by a whole lot of excellent specialists, and we frequently have reasons to get curbside consults, for lack of a better term, with our specialists, with the patient we may have right there. So we can certainly use our telemedicine platform to facilitate that. Then we have some pretty long waiting list for outside referrals. And so a lot of those, we can alleviate some of the burden on our specialists, our clinicians on faculty, and our outside referring veterinarians, also by using telemedicine to facilitate that relationship. And so that's why I'm here tonight.
Excellent. Thank you, Dr. Teller. We're going to turn next to Dr. Frankel. Tell us a little bit about why this conversation is important to have right now.
Sure. Hi, everybody. Thanks for having me. I'm Caleb. So I have two roles in the profession. So I'm a practicing emergency veterinarian. I have spent my entire career in very large specialty hospitals. I currently practice at VSEC in the Philadelphia area, and many of you on this call know me from Instinct. So I'm also crazy and started a software company. It's not something I ever thought I'd be doing, but I did it because of the same reasons why I'm here, which is for as long as I can remember, I've been obsessed with improving operations and some of the challenges that we face in the clinical floor through using technology.
Excellent. Thank you. We are going to turn to Brendan Lynch. If you're ready, we'd love to hear from you.
I am. Thank you for having me. So I head up innovation at VCA Animal Hospitals. We've got about 1,000 practices that cut across GP and specialty. And in my daily life, I'm focused on driving incremental and step change innovation at VCA. We're looking to address some big challenges, anticipate trends, and really pioneer new ways of doing business. And some of that clearly is telehealth and virtual care in today's world. Why today, why I'm excited to be part of this conversation, why I think it's important is, I think a lot of people think of virtual care as this replacement, but we like to think of it more as a supplement and a complement to in-hospital care. So as we look at that, there are different things, and like Lori mentioned about curbside use in today's world. There have been some new ways and some interesting things that we've seen trends increase around virtual care and digital means that are helping to allow our hospitals to do more with the same teams that they have and better care for their patients, while also finding more efficiency and productivity in their life, which makes their lives better. And we know that they're challenged with that every day. So I'm just excited to be part of the conversation and look forward to helping grow virtual care, not only at VCA, but also at other hospitals.
Excellent. Thank you. Dr. Sue, are you ready to give us your initial thoughts?
Sure. So I'm Sue Ettinger. I'm like Caleb. I wear a couple of different hats. So I work full-time for VCA. I'm a boarded cancer specialist. And I also, well, I used to speak in person a lot more until COVID hit, but now I'm doing a lot more virtual. And when I was out on the road speaking, to raise cancer awareness, I would meet so many veterinarians who, didn't have cancer specialists in their area and were looking for consults. And it really, brought up this need. And there's always been a need for more more consults between specialists and general practitioners. And so one of my ideas was, well, what if I could do more consults? And so I met with some friends, and that's where FIDO was born. So I'm chief medical officer of this new company, and we just launched during COVID, and it is a teleconsulting company to connect general practitioners to specialists. And we now have oncology, medicine, dermatology, and are adding surgery and nutrition. So my frustration has been, how to connect more general practitioners to specialists and how to use technology. And since, to be honest, technology is not my forte, I brought, some colleagues of mine who are much more tech savvy than I am. And, we were able to build software to create this new platform to connect and, hit all these pain points.
Terrific. I'm sure we'll be asking you more about that in a little bit. Dr. Dauphin.
Hello, I am Dr. Dauphin. I am a general practice practitioner who works for Pet Care Oncology. Pet Care Oncology is a company that provides radiation oncology to patients. I work directly, through the guise of technology, work with a radiation oncologist who creates the treatment plan, and I am the one on site that carries it out for patients. I think that this is a really great conversation to be having right now, because telemedicine is pretty much a natural progression in veterinary medicine. We've been seeing it around in human medicine for a while, and with COVID, I feel that this progression has been sped up, right? So it's a great time to be having this conversation, and I feel that as a general practitioner too, I am able to be part of a facet of medicine that I normally would not have access to, and certainly can expand that to my patients that I see in the clinic.
Excellent. Thank you, Sheena. We're going to turn next to Dr. Neil Malden.
Get myself unmuted. My name is Neil Malden. Like Sheena, I work with Pet Care Oncology. I'm a board certified internist, medical oncologist, and radiation oncologist, though the hat I wear the most these days is that of radiation oncology, and serve as the chief medical officer for Pet Cure. We've been interested in telemedicine for a long time, long before COVID, because the technological advances on the treatment platform have changed tremendously in the last decade. There's not very many radiation oncologists to go around, and there's not very many machines to treat patients. So our entire interest has been, how can we expand our reach? In the old days, when a definitive or curative intent course of radiation took 6 weeks to deliver, a family probably wasn't going to drive 10 or 12 hours to consider therapy. But now with stereotactic and some of the more aggressive forms, where we can precisely target these tumors and treat to much higher doses, we can do a curative intent course of radiation in 5 days now. And so we felt it was very important for us to have a way to have a conversation with people that perhaps lived outside the normal, what we would think of as a normal referral catchment. And more importantly, we thought it was very important to have that conversation early on in the process, rather than having somebody drive all the way to see Sheena and do a 12-hour drive only to find out that, yeah, we don't really think radiation therapy is a very good idea in this case. So, I think it is an important conversation to be having. What we're really interested in now is finding a way to partner with all of our veterinarians a lot more efficiently. We've talked about curbside consults. We call them hallway consults. but we really are very actively trying to find a way to make ourselves more available and to have conversations much earlier on in the care path for any individual patient.
Thank you for sharing that. Dr. Campbell, we're going to turn to you. Tell us a little bit about yourself and why this conversation is important to you today.
Thanks so much for having me on this panel. This is an exciting moment because I'm noticing a tremendous uptick and a groundswell of interest in telehealth and telemedicine. And as you can see through ACVS's platinum sponsorship, this is particularly important in the surgery world. I'm Courtney Campbell, a boarded surgeon out here in Ventura, California. And I also have been a media correspondent for quite a while. And it's been so much fun actually in both worlds, actually interacting with general practitioners, surgeons, and the day-to-day client, just on the ground, in the trenches, talking to people, trying to meet them at their need. I mean, look, I think a lot of us, once we saw 2020 hit and just how the uptick and the intensity increase in terms of caseload, we said, we're just going to grit our teeth and we're just going to get through this and we'll return to normal. And I think a lot of us understood really that there is no return to normal. This will be the next normal or the new normal. And instead of gritting our teeth and swallowing hard and getting through it, we're going to have to innovate our way out of it. And so for me, this is a really important conversation, just being able to not only meet the demand, the increased demand of clients, but also the increased pressure that a lot of general practitioners are feeling because they literally just can't see all the pets. And so they're getting as far as quality of life and work-life harmony, this conversation is super important.
I appreciate that. Thank you for the words. Before we turn to Anthony Ormondo, I just want to remind the audience that we do have two opportunities to engage with our panelists. There's the Q&A, which is a little button on your menu bar on the bottom. And then we also have the chat open. The chat will be for you to utilize when we ask a direct question to the audience, and the Q&A will be questions that you can pose to the panelists that we will try to get to within this hour and a half. And if we can't get to that within the hour and a half, we will definitely get answers to all your questions and respond to them in a follow-up email. So with that, I want to turn to Anthony Ormondo to tell us a little bit about himself.
Hello, everyone. I'm Anthony Ormondo. I am the Client Experience Manager at Red Bank Veterinary Hospital in Tinton Falls. What I am really in charge of is, the total care of the client and mapping their journey and removing obstacles that can get in the way of that. And communication sometimes, I shouldn't say sometimes, happens to be a lot of that. And I think that's one of the reasons why this is so important to conversation to have right now. We want to be able to be as accessible as possible to our clients. And one of the reasons to do that is to meet them with how they're comfortable with communicating and with all the different technologies that have, surfaced over the last few years. Not everybody wants, in person. And I think COVID's kind of showed that it is very possible that it can be done through a bunch of different means, including telemedicine.
Excellent. Thank you. I just posted a question in the chat. We would like to know, as you're listening, what virtual solutions are you utilizing today, if any? I think that's an important question to just kind of throw out there early on so that we can get a better feel for what everyone's using. We've asked our panelists what they're using, and I'm going to turn it to Joanne to talk a little bit more about each one of them.
Thanks, Allie. So we started by asking each of our amazing panelists to answer the question, how are you using virtual solutions to solve service delivery problems in the specialty space? And some of these panelists told us that they use Slack, that probably many people are familiar with, to connect and streamline the referral process. So I was hoping that those who do use Slack on our panel can talk about how you use that and how it has impacted those conversations.
I use Slack quite commonly. I would say daily at my work. So as I mentioned before, I work with a radiation oncologist who's actually in another state away from me. And she's kind of doing telehealth conversations in the background while I'm going about treating pets and staging them throughout the day that she's already spoken with. Slack allows us to instantly communicate about a particular patient, about a particular conversation that she's had or I had with the client. And it's instant like a conversation, but also allows us each to chat with each other in our own time as we're going about our daily tasks. The other thing that I do like about it is that I can interface with the entire company, and it does categorize conversations based on what the subject is. You know, if we're having technical difficulties within a clinic, if we're talking about patient care, if we're talking about, you know, HR things. So very multimodal in that respect.
Does anyone else have specific comments about Slack? I was going to ask Dr. Dauphin one question. I use Slack quite a bit in my work, and I'm curious if you could share with us how you organize Slack so that you don't miss anything on a particular patient. Do you just use the search function, which is pretty robust, I must admit?
I just use the search, although I'm sure there's probably a more intelligent way to categorize things. Sometimes too, I have, I think there's a way to like tag something as well for later and move it to like a different conversation so you can find it easily. But you're correct, I usually use the search.
Dr. Campbell and Dr. Malden, I know you both use Slack.
How did you
Well-
know? Could you see the look on my face whenever you hear that Slack message go off? No, I'm not. I was going to say I cringe. I'm kidding. It's awesome because it allows you to conference with other clinicians. We typically use it as a communication for emergency hospitals. There's our sister hospital, our collaborative partnership we have with an emergency hospital, and they can reach out to surgeons if there is an emergency case that comes in that needs surgical intervention. And sometimes it comes at the end of a very long day. Sometimes it comes on a weekend, but it enables you to turn off those notifications if you want to a respite from Slack. But whether it's pictures, video, communication, all of those digital means, those digital platforms, it allows you to communicate through there. And yes, you're completely right. By having separate threads or separate rooms, you can absolutely tailor your conversation specific to the people that you're talking to. So yes, we do use Slack quite a bit. And I'm not sure how you could tell.
I'm just intuitive that way. And you told me in an email.
Okay, that helps.
Dr. Malden?
Well, I mean, as Sheena's already said, Slack is an integral part of our clinical communication thread. You know, we are trying to coordinate communication across seven hospitals across all time zones. And, you know, the response time tends to be pretty rapid. If Sheena needs help on a patient and the rad-onc that is typically covering the Pittsburgh location is in a consult, there's 9 other radiation oncologists if there's that need. Another thing we're using Slack for, we are really working on developing an affiliate portal, which allows any hospital that we work with to kind of opt in to using some of the tools we use, like video image review and things like that. And we're using Slack as a way for them to initiate a sort of a virtual hallway consult. So there are Slack tools out there that you can set up as a chat, and the person on the other end of the phone doesn't have to have Slack, doesn't have to be installed. All they have to do is use the chat function on their phone, and it puts that conversation directly into a dedicated Slack channel that's monitored by different groups of people, depending on which channel it is. So if a specialist or primary care vet had a question, took a picture of an oral tumor, said, hey, I think this is a melanoma, can you treat it with radiation? and drop that into, send that as a text message to that dedicated Slack channel, we're all going to see it and be able to respond to that, probably not in real time as much as I would like it to be. And in the clinic, sometimes a 2-minute delay may as well be an eternity. Our long-term goal is to really sort of nail down and make ourselves more available and more efficient at answering some of these questions that happen from people outside of our hospital.
I'm seeing several questions coming in about Slack, and I don't want to stay on this topic for too long because we have a lot to talk about tonight. But does anybody else have any other insight into Slack versus WhatsApp or MS Teams or any other platforms that they're using for these kinds of communications?
I'm an old dog. I started with Slack, and I'm going to stay with Slack until somebody shows me there's something else that works. We do partner and work a lot with Teams. And if I would have started with Teams first, then I would probably be a Teams lifer. For me, it was purely, we picked Slack day one and it worked for us. It works really well. And I can't see us changing it unless there's just something so spectacularly better that comes along that you can't afford not to.
Mm-hmm. I'm actually curious, Dr. Sue, when you were building FIDO as a platform, did you do the market research on all of the ones that are available in kind of a homebrew type of environment? We've talked a lot at the VVCA about, using Zoom versus a platform, using FaceTime versus a platform. So I'm just curious if you have anything to add to the kind of limitations of Teams and Slack.
So we actually use Slack within the FIDO team for daily communication, just day-to-day weekly communication. But we built our proprietary software for the communication between the specialist and the general practitioner. And that was when we started. At first, we were looking at softwares that already existed, and we were trying to look at something that would store the primary care veterinarian, which is our client in a sense, and then could upload all of the medical records. And one of the things that was really important to me was that we uploaded medical records and could go through it. So we wanted the primary care veterinarian. So we needed to be able to upload the records, all of the patient information, and then we wanted to be able to customize it from specialty to specialty. And so that was when we were going to piecemeal a bunch of things, and we needed video capability, and we needed a calendar system, and we started to piecemeal it together, and it was starting to get really expensive. And that's when we turned to Dr. Mary Gardner, co-founder of Lap of Love, who in a previous life, as she says, was a software developer. And so she built the software from us from the ground up. And the great thing is dermatology can have a separate set of questions for us than can, oncology. And at first we were using Calendly, but then she's like, you know what? I can build this better. So now we have our own calendar software, and the calendar software is to be able to book the appointments between so I put in my appointments, the general practitioner can see when I'm available. We do use Zoom at this point for the video and audio chats, but that seems to integrate really easy. I guess Mary will probably build that in a year or so. But for us, it was just, I'm not the tech person. So, but you know what you're good at, and then you work with people who have that set of skills. But she was like, it just seems like the right thing to build it, because again, we needed certain pieces from things that existed, and nothing really existed for veterinary medicine the way that we were looking for. It was scary, I'll be honest. But she has a set of software developers that she works with, and they're amazing. And I'm so proud of our baby. I really, really am. But again, so we do use Slack, but that's for internal team communication. But the software is what we use to communicate. And what I love about it, just to add, is that we wanted me as a specialist, if I have a message to the general practitioner, like, hey, do you have a current cytology report? We have a message box within the portal, as we call, and then that will go to the veterinarian, and then they'll go into the portal, and then they can upload it, because we didn't want to have emails and text messages get lost. So everything goes through the dedicated portal, which was really and then they get an email that there's Dr. Sue sent you a message, but it's all in the portal and it's all kept in one place, because that is, you guys know that, right? Did I get a Facebook message? Did I get a text message? Did I get an email? We wanted everything in one place. So it's exciting, but it's been a process.
Thank you for that perspective.
I would love to ask Anthony a question. Anthony, you had a unique situation where you had a dentist working at Red Bank in New Jersey, but living in Colorado for quite some time before you relocated to New Jersey. So how did you use telemedicine in your practice before he moved? And how did his consults and conversion rates differ when he was in person versus being virtual?
So I'll answer that first question first. Before we found a dentist that would work with our criteria and with our patients, we didn't use telemedicine at all. So he was our pilot, and basically we wanted to make it work with his schedule. So he would do AirVet telemedicine consults Wednesdays and Thursdays, fly in on Friday, and then do his dental oral surgeries Saturdays and Sundays, and then fly back. And we did this on pilot for about a month and a half, January. Oof, wow, so long ago, January 2019 to February. So he was able to fit in per day about 6 to 8 surgeries, depending on severity. So we wound up with a conversion rate from the consults of about 56%, about 32 full surgeries, which is really great as like a proof of concept that in such a short period of time with someone that was coming from Colorado that, you know, none of our RDVMs actually knew anything really about, except for what we could push out through our referral relation managers as quickly as we could. You know, he continues, now he's ours and he's here, you know, 5 days a week. We still use telemedicine. And the way that he does it now is it really speeds up his, it speeds up his rechecks. So he spends much less time doing rechecks, so he can do more time with consults and you know what is most important to him, which is the surgeries.
Awesome. Thanks, Anthony.
You're welcome.
I'm going to jump in and tag on to that conversation because what we heard from Dr. Campbell is very similar in that he uses telemedicine for rechecks. And so I'd love to hear a little bit about that, Dr. Campbell, and where specifically where you think that could go next, in addition to just rechecks. Or do you see yourself expanding the use of telemedicine as a surgeon or specialist in general?
Ask yourself this: have you ever tried to do a lameness exam in a cat, and how did that go? This is always a challenging ordeal. And one thing that's really been proven through a lot of studies, whether it's through pressure platform analysis or gait platform analysis, is that when dogs or cats or any animal comes in the hospital, stress can mitigate, hide, obfuscate the lameness. And so if you get a chance to use videos to see dogs and cats or any other animal, how they're walking at home, that may actually be a true measure of their lameness score. And so you can use video, you can, particularly in the agility world, if they are missing a weave pole or they're just not hitting their turns right, or if they're slightly off, you can take those runs, those agility runs, and put them in slow-mo so you can actually see where they seem to be the most uncomfortable if they're missing turns. And so whether it's a feline lameness exam, whether it's a canine lameness exam, whether it's an agility run, or whether you're in very intense wound management among general practitioner and specialty, where you can take a look at a video or a picture from a general practitioner, and you follow that wound as it's beginning to heal and figure out what would be the ideal bandage dressing. I think the notion or the concept of using teleconferencing and televideo is something that we really, endorse and are committed to. Now, of course, we all know on this conference, you've got to establish that VCPR, right? So you obviously have to have that relationship. But if you're talking specifically to your general practitioner, you know, who is, like, as Dr. Edinger said, our clients, then you already have that relationship with them and they trust you, and you essentially can use that platform for whatever case you're seeing, if they're open to it.
I actually just want to tag along that a little bit more. Dr. Malden, at PetCure, you've been using telehealth, including video conferencing, as you were talking about, for quite some time. So I've got a couple of questions. First, how are you addressing any legal concerns with needing a VCPR? Because I know you've worked through that. And then I'll ask my second question once you're done with that.
All right. Well, I mean, the VCPR question certainly is one that warrants some consideration, and that I think we've probably all spent a lot of time thinking about. So we use remote document signing. None of our telehealth consults happen without a signed informed consent. And we don't actually use telehealth consult as a term. We use telehealth visit because a consult to me implies that there is a physical exam done in that patient of some type, or that at the end of that process, you are going to be making patient-specific treatment recommendations. And so what we tell people is this is a preliminary conversation. You know, you live in Ohio and you're a long way away from our nearest center. We want to talk to you about dogs that have brain tumors, give you the general gist of that conversation, and then let you decide whether you're going to proceed on to have a VCPR established by seeing a doctor at one of our sites. So, you know, for us, it is all about educating people. Do they want to take the next step? You know, we're very clear that we cannot make patient-specific recommendations based on a remote visit, and that we won't do that. So that is how we protect ourselves. You know, it's interesting to see. I think the things that we all saw change really rapidly was once COVID really got into full gear, then in both human and veterinary medicine, suddenly the telehealth requirements started changing pretty dramatically. And I see that as a bit of a genie. I'm not sure that local regulatory agencies are going to be able to put that genie back in the bottle once this is done. You know, as Courtney mentioned, you know, that it's not we're going back to normal. This is what our life looks like now. You know, the technology genie is running amok right now, and that's just the way it's going to be, I think.
Now, Dr. Malden, you have obviously with PetCure, you're doing a lot of these tele advice, or as Dr. Smith calls them, having these conversations. One of the concerns that I hear about telehealth that specialists have is about the conversion rate, right? If you're having these conversations via teleconference, do you see a difference in your locations where you have an on-site radiation oncologist versus a radiation oncologist who's participating in these conversations virtually?
No. And we track all of that stuff really closely. And if you look at our overall conversion rate for the company, so be that remote versus one of our sites that has an on-site radiation oncologist, the total conversion rate is probably somewhere in the 45-48% range, maybe going up a little bit over time. But one thing that's very interesting to us is that 60% of all cases that we treat within our network have had a telehealth consult as their first point of contact. We think that does two things. We think it prepares the owner for what the reality of stereotactic radiation is. Fantastic. It's Star Trek-y stuff, but it's also expensive. You know, and let's have that conversation now, not after you've driven 10 hours and find out that there was never a possibility of this helping you. or being able to afford it perhaps. The other thing is it very much pre-selects for our doctors. You know, if you have a telehealth consult and decide to take that next step and go to, you know, diagnostic CT scan, if you get to the point of diagnostic CT in our world, there's about a 90% chance, 90+% chance you're going to treat your pet. So we feel that that is a great, you know, sort of efficiency measure for the doctors. We are sort of pre-selecting people that are likely to want to treat before they show up at their hospital. So like I say, we would say across the board that a doctor that sees a patient that sees Dr. Boschevin as a radiation oncologist in Arizona, and a patient that sees Sheena working with Dr. Pullman, her radiation oncologist who lives out, you know, Sheena's in Pittsburgh and Kelsey lives in Colorado, you know, that the conversion rates for those two are going to be exactly the same.
Awesome, thank you. And we're getting a question coming up in.
Add something as well.
Yeah, go.
So I think, you know, one of the concerns with specialist consultations is, you know, that they won't go to a specialist maybe locally, but I think, and especially we've seen this with COVID. I just got an email from a general practitioner in the Pittsburgh area, and she wanted to know about doing a consult for her client because the wait times to see an oncologist in her area are 4 to 6 weeks. And the client, you know, we all know, like with cancer, and it's not just with cancer, but there are evolving client expectations. And so this client's not going to come see me, though I did have a client drive up from Florida for 5 months for CHOP lymphoma and is staying in the metro New York area in the winter. But most clients are not going to drive to see me, right? But they want the information. So by getting these consultations, it doesn't mean that they're not going to see the specialist in the area. It just allows the veterinarian to provide that information and, you know, to talk to them about the different options. Do they want to do a full chemotherapy protocol? Do they want a palliative? So I think, you know, a lot of the fears and concerns that people have about some of these tele-advice and teleconsultations, a lot of the cases I do consults on still go see their local oncologist in the area. It just gives the client that information that they need because they can't get in for a week or two. And it just helps them walk through what the, you know, the different options, what diagnostics they're going to do, what diagnostics they might not do. And so, you know, it's just one of the couple of pain points that they have, but, you know, the waiting times can be really rough. And I think COVID, has really exacerbated that. It's always been a problem. And the geography, you know, as Dr. Malden has pointed out, is a big issue. And it's not just for radiation oncology, but there are parts of the country. I just did a consult for someone in Alaska. It's 6 hours. The client already drove 6 hours to see a surgeon for the CT scan, and it's going to be 6 hours to go back and see an oncologist. So that's a big constraint. So I think that's the pain points that we're trying to help: geography, financial constraints, evolving client expectations, and these referral wait times. So I think those are the things that telemedicine, teleconsultation can help for the clients and the veterinarians that need it.
There's a lot of question about, well, how do we charge for this? So I'd love for each of you to answer this question, but we'll start with you, Dr. Sue. What are clients, what is an acceptable charge? Is it comparable to an in-person consult? How do you handle that with FIDO?
Yeah, so FIDO is consulting with the specialist to the general practitioner. And then the question that we often get is, what do I do with that? Do I, how do I charge the client for that? And we give advice to the general practitioner what to do, or to the primary care veterinarian. And some will charge the client that price, and then some will mark it up 1.5 times like they would other diagnostics. But what I think, the way that I look at the return of investment is, often you may be doing some blood work, or we'll say, hey, you can do 3-view chest radiographs before you see the oncologist, or let's talk about doing an abdominal ultrasound. So there may be return of investment from the other diagnostics that you're going to run in-house that I'm directing them from. So you don't have to look at marking up the cost of the consultation. Our consultation to the veterinarian is $300. like I said, sometimes they charge the client that directly and sometimes they mark that up. But I think the return of investment is the faith and the trust that you get from the client and those other diagnostics that you may be keeping in-house while you're working up these cases. Some of the cases that I've done, have biosafety cabinets and they do chemotherapy in-house, and some of them do refer.
Great. Dr. Campbell, I know you're doing teleconsultation. Do you charge differently for the virtual rechecks versus an in-person recheck?
Now, that is an issue, particularly that we are struggling with in terms of monetization, in terms of charging for that, because I just want to give a shout out a little bit. And again, I know that this is about technology and using telecommunication, but I just have to quickly give a shout out to both hardware and also personnel. Because what we saw in the chat is we saw this sort of consensus building around the fact that some people feel overloaded. So you might get 5 Slacks, 3 text messages, 4 Facebook messages, emails, and you go home and you're just like, I don't even know. I'm not responding to anybody. I can't do this. And so if we know that this industry in particular, all of us, struggle with either a work-life balance, if you believe in the term, or work-life harmony, whatever you want to believe in, there has to be a limit on how much you can service, how many people you can service. And so what we've kind of developed is, as we know, veterinary medicine continues to grow at 4% each year. And then in 2020, that blew it through the roof, right? So we know it's not 4%. So let's just say it increased 25%. If your personnel, if your paraprofessional staff has not also increased commensurate with the increase in client load, then you're drowning. You're up that proverbial creek with half a paddle. So what we have done is we found personnel who are highly refined, really gifted at monitoring. And I'm just gonna, I said hardware, it's just a work phone, right? And sometimes I have the work phone, sometimes other people, but monitoring that device so that they can look at Slack, look at the emails they're getting from clients, look at text messages from general practitioners. Because for me, it's about meeting them where they are. And we've talked about a lot of different platforms, whether it's Zoom, FIDO, we talked about Doxy.me, and I think these are all amazing. But there are some general practitioners who I talk with and primary care veterinarians who they're just more comfortable sending me a text message. So I'm just trying to meet them where they are, and finding a way to monetize that is difficult. I would definitely say if there is a way to monetize that or charge for that as far as a recheck, it would be incorporating that within the initial fee for the surgery. And therefore, a lot of clients may not feel like, how come every time I walk in this building, I have to pull out my wallet? If it's integrated within the original cost, they know they have at least 3 tele-advice, which I really like that angle, or telehealth visits integrated in the final cost. And I think that might be a way to circumvent that this sort of the dyspeptic attitude towards constantly coming and the various charges associated with that.
Great. Anybody else have comments on the cost piece?
I think one of the challenges is clients have been used to getting us on the phone for free for so long, and now they're not seeing us because they're curbside. So I do think taking off my FIDO hat and putting on my in-clinic hat, I do find that challenge for, the pet has a problem, you want them to come in, they just want to talk to you on the phone. They don't want to pay for that phone call. They just want the free advice. But if it was a telehealth phone call, could you charge, follow up, but can they come in? Then it would be a recheck appointment. So I do think there is that struggle to figure out how to balance that, because again, I have often gotten on the phone just to talk to my clients for free in between appointments when new problems arise. So I, as a clinician, feel that struggle with how to then turn that around into a telehealth checkup when it's an ongoing problem or continuing problem with my cases. So I could use some advice as a clinician there. The FIDO part's a little bit separate, but I think as a clinician, Dr. Campbell, it can be challenging.
No doubt. And I just want to say this one piece. There is a sort of a dichotomous idea behind the charge, in that I think we conference and talk with primary care veterinarians because we want to, there's this undercurrent of a competition of the client's finances, resources, the patient itself, and there really shouldn't be any competition. It's a collaborative effort. And so I think we conference with a lot of primary care veterinarians because we realize we're instilling a sense of goodwill, a sense of hyper availability. You can always get us on the phone, and maybe potentially that might lead to additional referrals. But then the other component is directly with pet parents and pet owners is how do we charge for that? So there, again, just like Dr. Edger said, I'm open to advice too, whether it's how do you charge for either your consults with a primary care veterinarian, which probably many would argue that might be a lost leader, versus charging for with a pet parent for that very valuable advice. And
I meant with the pet parent. That was what I was talking about. The challenge as a veterinarian using telemedicine with clients is challenging.
100%.
Hopping on the phone to me with a general practitioner to give 5 minutes advice on a case is not a big deal, which is different than the full consultation that you get, when you do something like a teleconsultation with FIDO is very different. But yes, I still hop on the phone with the vets in my community and talk to them about how to manage lymphoma for sure, but that's going to be different. But I was talking about the clients and how to convert your follow-ups like you were doing in your clinic with your post-op or your lameness cases and things like that. That can be challenging.
It's super challenging, and I completely concur with you. We started to integrate that in with the cost, and I think it's so important to have that, obviously, that initial physical exam, orthopedic exam, neuropathic exam, and then build on it from there.
Yeah. From the VCA side, that obviously not speaking from a clinician side, speaking from an executive side, that this was a big topic early on. So just to be perfectly frank, we really weren't doing video visits pre-COVID. It was on the roadmap. It was on the radar. We were working aggressively towards it. COVID put things into high gear, and this was something that was raised numerous times. We didn't have an answer for it early on. I can say that while we do give a lot of flexibility to our providers within the hospitals, clients are generally okay paying for care. Like whether this distinction between whether it's by phone, by video, in person, I think is a little bit of something that we're almost self-creating. But I do think the clients are more willing, especially in today's world and in things that they're getting outside of veterinary medicine. They're coming very accustomed to this in the human side of human care. So I don't think it's as much of an issue as I think we generally feel that it is. And at VCA, our recommendation with our providers is if you're going to be doing a video visit, you charge the same amount as you would whatever that rate would be for an in-person visit. And we don't see generally a lot of pushback on that because it's really driven by convenience and access. And those are really important to clients and they're willing to pay for that.
Yeah. Just to piggyback on what Brandon was saying, everything we did with Dr. Haggerty on the dentistry side and what we also do with Dr. Klein, who's our nutritionist, it is charged no different than a regular consult to the client.
Yeah, and I was going to echo what Dr. Campbell said. I'm seeing a lot of chats about how you charge and wrapping this charge into your original charge is so powerful. Getting creative can be incredibly powerful for compliance. That's what we found. A great example of this in our, I'm an emergency room clinician, so it's a little bit different, but I haven't removed sutures from a patient in probably 12 years. And everybody wants to know how that's possible. It's possible because a long time ago, we made a decision for the way we charge our wounds. If I do a drain placement or a wound management, the recheck is included with our surgeons in this. So we were solving two problems when we did this. And what we did is we priced our wound care in the emergency room appropriately. And we were handling an incredible volume of these wound rechecks, suture removals. And we wanted people to stop showing up out of the blue. So we wanted them to schedule. So not only did we completely eliminate our emergency room volume on these because they went to the experts, the surgeons and the surgical residents, which we're fortunate enough to have. But they were scheduling them. We said, as long as you schedule it, it's free, it's included in your care. And it's a great example of how to start thinking a little bit differently about how you charge for things. And this, with virtual care, telehealth, this is a great way to start thinking creatively about those charges. I think people who are having trouble monetizing it are thinking traditionally about it.
Okay, great. I am going to take us in a different direction because we do have a lot of activity in the chat, and I want to make sure that we get to some of these pointed questions. Brandon, if you don't mind, I am going to ask you on behalf of Audrey Weistrach, what are the most frequent use cases you see for teleconsultation at VCA? And have you set up an internal network within VCA for specialists and GPs to connect?
There's a couple questions baked into that one. So I'll try to start with the first part. We do different things for virtual care. So it kind of depends on what the channel is. If we're talking about live chat, which is something that we do, and we're doing thousands and thousands of those a month, which are offered for free for our Care Club members. And then we charge $19.99, which is really decision support. And it's staffed by CVTs with DVM escalation as needed. So with those, we get all types of stuff, and I don't have the exact metrics in my head of what the common use cases were, but it's a lot of educational components. I would say 50% of them end up being referred, well, I shouldn't say 50%, call it a roundup. 40% end up being referred in hospital for additional care and diagnostics. 50% are watchful care or general information. And then we've got around that 10% in the ER space, which is, hey, you have an urgent situation, we really recommend that you seek care right away. But it really runs all over the place, and probably wouldn't be a lot different than what you would see in practice. These are people that they're reaching out through that means because it's extremely easy and there's no barriers to entry. So it's super convenient, super accessible. So they're not going to Dr. Google, they're going there first. And what's really interesting in that aspect, and something I can talk about because we published in a blog, was that what we're seeing is north of 60% of our clients that engage with us through live chat end up booking an appointment within 48 hours. So it speaks to some of the other panelists that you're validating and prepping them. And then when they end up coming in practice, they're actually more prepared and more willing to take the doctor's recommendations. So that's why when I use the terms like supplement and complement, it's really a great way to go after that. So I know I couldn't speak specifically because I don't have those numbers in my head, but it's not unrepresentative of what you would see in the practice. And there were a couple questions in there. So can you remind me?
Of course, yeah, absolutely. Has VCA been able to set up an internal referral network between specialists and general practitioners?
Yeah, so obviously we have in-network GP and specialists. We don't have anything that's unbelievably proprietary that's different than externally. I think that's a great opportunity for us to make that experience smoother and frictionless, and something where we see a lot of opportunity in the future working towards. So we see opportunity there. As many of these things, it's an evolution and an iteration as we continue to get better and better at what we do. Now, we do have within the Antech side of the business, Antech diagnostics. So similar to where they can actually seek out, but that's different than the GP to or the primary care to specialist referral.
Got it, great. Another question that is directed at someone specifically is Dr. Ettinger. You mentioned the $300 charge for the FIDO consultation. Someone's asking, how long do you spend consulting with a referring vet? And how much specific info are you leaving the vet with to relay over to the client?
So it is a ton of information. So it is as thorough a consultation as I do when I'm seeing the patient in person. So all the medical records are uploaded. So one of the other co-founders is Caitlin DeWild, who's a general practitioner. And one of her pain points was when she was doing some of the other consultation services was she had to verbally vomit a lot of the information. And she was always afraid she was going to forget some of the information. And when I was talking to some of the other specialists that we hired to be some of our consultants, they said one of the things that they always prevented them from wanting to do something like that was not getting all of the information because they didn't have the record. So we review all of the medical records. The veterinarian can just do a written consultation, but we give them the option of doing a video call or an audio call with us. And then they get a full medical report with all the different treatment options, protocols if they're going to do, if they want to refer, so it goes through. And then we also provide them handouts for the owner. So we give them client-facing information. So a handout about lymphoma, a handout about Addison's, a handout about different dermatopathies that Caitlin, who's just beautiful in the graphic arts, has branded for them. So we want to provide for the general practitioner the information to share with the veterinarian. And then for me, I will also share like my different YouTube videos on the topics. So it's a pretty thorough consultation. And then included in that, within 2 weeks, they can schedule with me or the other specialist a 15-minute Zoom call, audio call, or if they want to do it via email, an included follow-up, because one of the things that we didn't want them to feel was, okay, what if I get all this information and another diagnostic comes back and I don't know what to do with the flow cytometry? So we include, sorry, I live by a train. So we included that in it as well. And then if they want additional follow-ups, they can follow up with the same veterinarian and we will have all the information in the portal, because again, one of Caitlin's pain points was sometimes she would call back and have to start over with a new specialist about the case. So it's pretty thorough. I have to tell you, we have repeat users, which means that people have been happy with the service. And I also have to say, this morning I did a consultation with a veterinarian from India, which I was pretty excited about, with a dog with TCC. And what was super cool is they sent the urine to Antec Lab for the BRAF urine test, which I thought was also amazing. The dog had a CT scan. It was just, guys, think about like how I'm getting really excited, but how cool is it for telemedicine, teleconsulting? I did a consultation with a vet for Sheltie with a dog in India, that has TCC, and they FedEx the urine sample to the US so we could run a BRAF test to confirm that the dog had TCC. Like, how cool is that? Like, it actually brings tears to my eyes, and like, they're comfortable giving chemo, and the owners are on board. Like, this is what to me what teleconsulting is all about. So I know that was a really long answer, but this is what gets me excited.
Awesome, thank you. So shifting gears a little bit, again, there was a question that came in for you, Caleb. What specific workflows and friction do you see the need to solve for in software development? Because our industry is so fragmented, how do you see interoperability of for the practice and for the customer?
Yeah, somebody wants to push my buttons, I guess. So, yeah, look, this is a tough challenge. This is not unique to veterinary medicine. I've been a student of healthcare technology and software for a long time, and this is a huge challenge in human health, where it's even incentivized and mandated by organizations like governments. So yeah, it's something, that I started my career trying to work on, quickly became frustrated and decided to build a solution, for some of this. There's no easy answer. I think one of the things I love to lecture to our students, because, the veterinary students are the next generation. And I think part of this is going to be a culture shift. It's going to be all of us demanding of the companies that, are putting these software tools in our hands, being able to be interoperable. And one of the challenges is with consolidation in the market, things are unfortunately becoming more proprietary before they're becoming less. And I'm, by the way, I work at a Blue Pearl hospital. You know, it's not anything against the consolidator specifically, but it just is an interesting challenge for our time in medicine, in veterinary medicine. And at the same time, we're just in the infancy of digitizing our practices. I mean, 90% of Instinct hospital installations are converting from paper to digital in this day and age. So think about that for what we do, which is pretty wild. But there's no easy answer to that. It's going to take all of us kind of demanding it. There are finally some opening of the kind of mindset to, you know, what's called APIs, which connect things. We're seeing a lot of that. Our software takes advantage of one that IDEX makes and does a really good job with. But yeah, I mean, it's something we're going to have to figure out.
Yeah. Well, Kayla, before we go off of you, I'd love to ask you another question. As an emergency doctor, first off, you have to be absolutely stretched to the max right now with everything going on. Long before COVID, emergency departments have been the backdoor access to specialists if the wait is too long for an initial consult. And we're hearing wait times of 3-4 months and more for clients to get in to see a specialist. And just like Dr. Sue, you're getting some of your consultations because people they get a diagnosis of cancer in particular, they're not going to wait 4 months before they can get some answers. So Caleb, I'm just wondering if you could talk about that backdoor emergency referral process. And is in your experience as an emergency doctor who is perhaps caught in the middle of a system that I would say is not the best system. So what parts of that work as an emergency doctor for you, and what parts do you think we could improve upon?
Yeah, that's another tough one. We joke in the ER, it's trickled down. We joke in the ER that there's a month to hour conversion of your wait to see a specialist to the ER doctor. So if you're waiting 4 months to see your specialist, it's going to be 4 hours in the ER. But it works out almost perfectly. But the caseloads have become incredible, right? For all of us. I talked to so many hospitals, many of you on this call about this, and we thought it was going to slow down. Like, you know, Dr. Campbell said initially, it's the normal. It's not the new normal. We've moved beyond that. And it I think about this problem a lot. It's all about setting expectations. So you know, being in the ER, we aren't too focused on the more traditional telehealth solutions that a lot of people are talking about here, right? I mean, it's just the nature of what we do. But if you really think about it, we're sort of the OG when it comes to telehealth because of our long relationship with pet poison control, right? That is an obvious kind of old school virtual care platform, and we've been using it for the longest. And a lot of our focus is on sustainability for me and my colleagues in the face of these tremendous caseloads. So you can't turn people away from the ER. We don't. I mean, that's just a policy we have. It is the backdoor in, but you have to first of all work with the culture of your organization to set the tone for your ER. I've been in a lot of places where the ER doctors think that's not their job, but I actually disagree with that. That actually is kind of the point of our job, to be there when nobody else can be. That's the summary of what we do, right? And that includes the specialists. It's not just the general practitioners. And I learned that very early on in my internship hospital. And you know, it was a place where they had a great culture for that. And I think that's the first thing, is expectations for your team, but then trickling that out into expectations for the clients, and helping them understand you know, what to expect. One thing is the wait time, right? You know, don't just make people sit out in your parking lot. I think we've all realized this. Get ahead of it. So when they pull up, tell them there is a 3-hour wait, even for critical cases, to speak to a doctor. Head home. We'll take care of your pet. There's no reason for you to sit in our parking lot. This doesn't have to be a tailgate party. You know, you can leave. We used to be really scared of letting people leave because of finances. We've thrown that out the window and realized it was never a concern to begin with. most people love their pets. They're not going to abandon them. And the ones that do, you know, it's not going to overwhelm us per se, at least where we are. So, so the back door, you know, getting back to the back door, look, it's part of our job. Having experience and judgment to help these pets as best they can. But you know, part of it is also working with great specialists, and I work in a facility where I feel supported. The specialists from afar using virtual tools help me make the best decisions when I'm out of my element as an emergency clinician. And so consulting with the specialist is obviously helpful. We have a system for getting in touch with the right person. Most clients don't have an expectation for you to reach an oncologist at 3 a.m. That's, you know, but if it is 5 p.m. and you have a really sick pet and it's a Friday night, I think it's reasonable to be able to offer the right kind of care and set the right expectations by working with your local specialist, even if you're in an ER only center. So that's my long-winded approach to that.
That was fabulous. Thank you.
Well, I'm going to jump in, and I'm going to first I want to recognize the work that I didn't know was happening behind the scenes. I just opened the Q&A, and I want to thank Dr. Malden and Dr. Teller for being right in there answering questions directly. That was an unexpected little piece of joy for me. So thank you for doing that. It's wonderful. Again, we'll record all of this and summarize it as best we can so that everybody can benefit from the reading after we're closed up. So Dr. Teller, you have to stop typing and stop focusing on someone else's questions for just a minute. I am going to ask you about what you're doing because everybody wants to know. We know
I want to know what I'm doing.
Well, this is a big question. We know that you're the first full-time telehealth veterinarian in academia, and we know that pet owners travel great distances to get to Texas A&M, and that you're facing long wait times for some of these services. Yes. How would you say telemedicine is helping you the best, or the school the best, and what are the challenges that the industry is facing about what's going to happen to those challenges? Like, is it wait time? Is it distance? Is it rural? Is it?
It's all of it. Yeah. Some of it has been said by the specialist already here, helping determine if these people should be coming in. They're driving hours. And so do we have the appropriate treatment to offer them? Are they willing to pursue that treatment? And so, as was brought out, it does help weed some of those out, so that when they do come, they are prepared and they're better educated. It's also been a tremendous boon for follow-ups, because if you can have a client that's come for a surgery or a neuro or an onco visit, and they've driven 4, 5, 6, 8 hours for that, and you can do a follow-up via telemedicine, you're saving everybody time on the road. And certainly during the pandemic, when a lot of these clients have to stay in a hotel or something overnight, they definitely appreciate the option of not having to do that. So it's been pretty tremendous.
Absolutely. Would you mind giving us a little bit of information? This is kind of off topic, but okay. I'm really curious, and I think the panel and the audience would like to hear a little bit about the program that you set up with your students doing outreach to the rural areas. Yes. I would love to just hear a little bit about the access to care part of what you're doing.
Yeah, so this has really been a lot of fun. Access to care is obviously a huge topic in the profession right now. And we got a grant from the Innovation School at A&M to identify a group in rural Texas that did not have access to veterinary care. This particular group was low income, and we identified them by working with our telebehavioral counseling service in the Human Health Science Center. So this group was already familiar with telemedicine because they were getting their mental health care via telemedicine. And so we identified a subset of those patients who had pets, who did not have a veterinarian. And we rounded up our students, drove to the little town, set up actually in their fairgrounds expo center. And we did physical exams, vaccinated, heartworm tests, parasite testing, all of that. Treated minor illnesses, minor wounds, and we're doing all our follow-up via telemedicine, and it's been pretty tremendous. Students have loved it. they've gotten to feel like they're giving back. They've had an opportunity to learn a different way to communicate with clients. They've been exposed to the clientele that you don't normally see at a tertiary referral institute. And the clients have loved it too, because their pets are getting care they would not have otherwise been getting. So hopefully when that study wraps up later this year, we'll have some good data to present on that too. Yeah.
Thank you for sharing. I'm going to tag on to that because I want to hear from you. You know, there are so many vet students right now. They might be studying for a specialty. They may be studying for GP, and they're not at Texas A&M. So how can we move the needle with educators to make sure that these young veterinarians coming out are ready to implement and ready to take on telemedicine? I mean, I've talked to some people that are involved in a new graduate group, and their pain point is, look, we're just learning how to be veterinarians, let alone be telemedicine veterinarians.
Right.
So how can we improve as a profession and educators? How can we improve those outcomes for students early on?
Well, they obviously all need to come to Texas A&M. But since that's not going to work, so some of the other schools, while they don't have somebody full-time dedicated to it, they are doing it. LMU is doing some. Virginia, Maryland is doing some. So I think the big piece is we know clinicians are doing it, and what we need to do is encourage them to utilize their students in part of the process, whether the students are getting the initial history through the telemedicine visits or reviewing some of the medical records ahead of time. And then even just sitting next to the clinician during the actual consult so that they're learning from it and seeing what that looks like, not only the medical piece of it, but communicating through a telemedicine visit is also different than communicating across an exam room table. And so I think that's going to be the biggest piece.
Thank you for sharing those perspectives. I appreciate it.
I would love to just put out a question to the panel, because I've had conversations with doctors in specialty practices who are maybe all on board with implementing some kind of telehealth, but they get a lot of pushback from their team. How have you all had conversations with your coworkers and, you know, just people who are perhaps resistant to embracing telehealth, to help them to come along? Have you been successful in being able to do that?
I'd say it's very hit and miss. But usually if you can get one or two people, in our case, in a service to engage in it, then the rest of them are willing to come along. It's going to be a little bit different in private practice.
So give it a try, is what you're saying.
Yeah.
Well, I mean, there are early adopters and late adopters, and the early adopters are going to be out on the front of the curve. You know, across our network, we have some of both. And, you know, obviously our remote doctors didn't have a say in it. It's like, if you want to be a remote doctor, you kind of have to do telehealth. But, you know, for some of the on-site doctors, there's very much different, differing views on it. And a completely and totally unrelated comment, but I am starting to rethink my decision to do this seminar sitting at my planning computer in my basement as it quickly gets dark in Western Canada. I'm feeling a little bit like a supervillain right now, which I guess is okay. I don't know. But yeah, I think that it's all down to comfort with the technology and comfort with where you are on the adoption curve. You know, the thing is that the adoption curve doesn't care what your comfort level is. At least I don't think so. I think it's going to grab you and drag you along whether you want to or not, because pretty soon, if the answer to a client's, do you do remote or do you do telehealth? If the answer to that question's no, that's going to be a determinant for them to move on to the next place that does, if that's what they really want. So it'll be interesting to see how it all plays out in the long haul.
I think also during COVID, one of the, you know, the pain points that veterinarians have had is, and Dr. Campbell alluded to this, is how busy we have all been, right? Like there's been COVID puppies, COVID kittens, people have been home looking at their pets, and there's such an uptick in the cases coming in. I always say cancer doesn't care if it's a holiday or not. Like my cases are just always steady all year round. So there's all these patients coming in, and then there's all this new technology, and what platform do I use? How are you guys accepting payments? Which one do I use to chat? Can I integrate it? And I think it's been really overwhelming for veterinarians. One of the veterinarians who used Fido, she's done it 4 times and she loves it. And then other people, it's like logging into the portal for the first time is overwhelming, but once they log in, it's okay. So I think adopting new technology is scary, and so I think anytime you're trying to do something new, you have to look at it from the other side, from the user. What is their pain point? What can we do to make this process easy? And I think sometimes what I think the pain point is not the pain point for, and I keep calling it the user, but for me, the veterinarian or whoever we're trying, the pet owner, whoever we're trying to get to adopt new technology. So I think that has really been the challenge. Adopting something new is scary and different. As Neil said, some people are like technology and some people don't. My parents have had to use new technology as they've been going to see their own healthcare professionals during COVID. And that's been, they're in their 70s, and that's been challenging as well to get them to do it, and then to get them to teleconference me in on FaceTime, But again, there have been early adopters and there have been people who won't. And I think the stress of COVID, no, I just want to send it to the oncologist. I don't care if it's a 4-week wait time. They don't want to figure out a new technology. So I think that has been an added stress. So how do we make it easy? And sometimes I've gone to the Facebook page and I'm like, oh my God, I don't even know which the best, for me as a clinician, which one should I be using? So it's overwhelming. And I think that's one of the pain points that we have to help figure out, which is the best, and what is the best for one practice may not be the best for the other practice.
Yeah, I was gonna chime in. My whole life is getting people to adopt technology these days. So I would give 3 practical tips that we think about, and I've lectured on these. But number 1, don't even do it if you don't have the leadership buy-in at your practice. The decision makers have to be bought in. It is not worth it unless they're all behind you. There's a graveyard of technology implementations of failures because of that. So don't go forward if you don't have that. Number 2 is make it small. Make it, I call it the V1 approach. Make whatever you're doing, make it as small and least risky as possible. Here, a great example is what we do with Instinct. So our software runs a lot of the teaching hospitals in North America. So those are tricky implementations, as you can imagine. They're big centers, and we used to not be smart, and we would go live in the entire center and take a Band-Aid approach, large animal, small animal. Everybody would be using it on day 1. It was chaotic. We got smart halfway through, and what we do now is we recommend we only go live with our software in the ICU on day 1. And what ended up happening is we've performed some kind of mind trick on the hospital, because the ICU gets used to it. You always have the people who are like, I don't want to do this, and then they start using it and they're okay. And then you get all the other people coming into the ICU and seeing that they get fancy toys and they don't. And so what happens is you get a lot of people, and this has happened repeatedly now, who come in and say, why can't we go live with this in oncology? You guys didn't even offer this to us. ICU gets it. In the same hospital, if we had gone live everywhere, oncology would have been complaining about it. So you can get strategic about how you implement some of these in small ways. And the third thing I always say is cater to your dinosaurs. So dinosaurs are not the age dinosaurs. So these are people who are going to be extinct if they don't figure out how to adopt different tools. That's what I mean by dinosaurs. And there are plenty that are young dinosaurs. But these people generally resist technology because they're worried about their patient care for the right reasons, right? And so the way you can cater to them, when we go live in some centers, we identify who those people are. I teach management to park themselves out on the floor with these, usually excellent nurses. And so that when there's problems or when there's a little bit of complaining, you're right there to address it, figure out what the issue is, learn from it. And so catering to those people, I think a lot of people hide from them on these implementations, but you can kind of go all in and lean in. And that's another tip that I've found is useful.
I'll kind of add on our end that I can certainly sympathize with, we've got over 5,000 doctors, just as many technicians. So getting people to adopt anything at scale is not easy, especially when it's new and different with the workflow. But the one thing that we learn time and time again is that it has to be built into the workflows of the practice and the providers. So when you put stuff side by side, it can be a great solution, but when it's outside of the workflow, we run into challenges sometimes. So and look, there's solutions that work really great. So I'm not trying to discount anything out there, but for us, where we found a lot of success is trying to really think about what is the workflow of that clinician and the team, and to build these things around them. The other part that we found successful, and COVID, I think, has been, everyone would probably acknowledge, is an accelerant for virtual care in certain cases. And what we've seen is, when you have a full caseload in the day, it's hard to kind of just start to distribute and going, well, I've just decided I'm going to start seeing virtual care cases. It's like, well, you're completely booked up all day within hospital appointments. Like, it's just not a real practical approach. But, and we're nationwide plus Canada, so we have regionality. People are in different states of COVID and what they let people in and don't let others in. But where we've seen some early success is with curbside. So we're losing this bond right now where clients cannot connect face-to-face with their providers. And we have some solutions that will do that. Did we build these solutions originally for that? No, we never saw that coming. But it's been an added benefit for some of these providers to even just start to trial the technology and see how it does work. And we think that this will actually yield a lot of benefits longer term, and we'll just see more adoption. So, kind of like in giving a little bit of things that we've seen work is make sure to build it into your workflows, and then try to find some of those quick wins in today's world. Because right now the teams are really struggling, and there are some things that can help right now that will continue well beyond the pandemic.
And I think that is a great topic for a future talk for us to have. I would love to talk about how some of these efficiencies can help the teams, because it's something that's near and dear to my heart, watching the struggles that veterinary teams are having, especially during these times of COVID and the burnout rates being higher than they've ever been. So on that note, I just wanted to say thank you to all of our panelists. This has been a great conversation, and I want to continue it. So thank you for giving us your time. Thank you to all of the attendees for not just your attendance, but also your involvement and the conversations. Allie, did you want to say anything?
Again, thank you to everyone. I appreciate all of your time, the attendees and the panelists. I know it was a long conversation, but much needed. And I think we have a lot of action items and takeaways from today. I agree with Joanne that we could probably set up another panel discussion next week and keep going. So I think what we're going to do next, Joanne, is just summarize our thoughts or your thoughts, and try to regroup and decide what we'll do next.
Absolutely. Thank you, everybody. Have a great night. And we'll talk to you soon.
Bye.
Good night, everyone. Thank you again.
Yeah.